So I just wanted to go over lab stuff. I know that you're going to get a little bit of that tomorrow. I just wanted you to get it from the monitoring perspective. And then I have a couple clinical cases on the back side where we can talk about that a little bit as well. So the laboratory tests, we're looking at electrolytes, blood chemistries, hematology, urinalysis, plasma levels, psychotropic medications, and other specific tests like pregnancy, prolactin, and thyroid functions. Oops. All right, let's stop. Okay. So why do we do this? What are we trying to do? Well, we want to be able to prioritize medical issues. We want to be able to rule out medical conditions that contribute to the patient's clinical presentation. We want to be able to guide the therapy selection as well, and able to monitor therapeutic levels and be able to monitor side effects from the medications. That's essentially what we're doing with all of this testing. These are the atypical antipsychotics that are out there right now that are likely to be on the PEP. And you can see when they were developed. Okay, so when somebody, golly, this thing's sensitive. It just moves faster than I want it to. It's jumping. All right. What? Why does it go to? Okay. This is frustrating. Go back. Let's try one more time. Okay. So we look at the second generation antipsychotics and metabolic disturbance. Okay, many patients taking SGAs will develop the metabolic syndrome. So we get a little hypertension, a little hyperlipidemia, and elevated glucose. So we see obesity, insulin resistance, elevated glucose, hypertension, high triglyceride levels, and high cholesterol levels. Low good cholesterol, HDL. So we see a low HDL. The relationship of the second generation antipsychotics and the metabolic syndrome remains controversial. It's limited, randomized, controlled, prospective, head-to-head trials. So there's not a lot of that. Most data are retrospective and epidemiological findings. Most studies are poorly controlled with respect to exercise and dietary restrictions. And there appears to be a greater association between both obesity and diabetes among the severely mentally ill, schizophrenia and bipolar disorders, for example, when they're compared to the general hospital. So that population would naturally have high propensity for hypertension, problems with glucose, and cholesterol. Weight gain, the high risk is, so when we look at the is that the right? Do we not? I'm just kind of paranoid. I want to make sure we're not skipping anything. Okay. All right. So weight gain, the high risk is clozapine and olanzapine. The moderate risk is risperidone, quetiapine, iloperidone. The low risk factor is lurasidone. The lowest risk is ziprasidone, aripiprazole, and olanzapine. De novo diabetes, mainly type 2, are an exacerbation of existing diabetes. African Americans are relatively high risk. FDA MedWatch drug surveillance, we see that clonazepam, 384 cases between 1990 and 2001, and the olanzapine, 289 cases in 1994 through 2002. One controlled study demonstrated increases in fasting glucose and fasting serum insulin over a period of 8 weeks, pointing towards insulin resistance in association with olanzapine. Risperidone, 138 cases, 1993 into 2002. So those are the cases by which all of these studies are based on. The glucose dysregulation will usually resolve in 2 to 3 weeks after discontinuation with the drug. If rechallenged, abnormalities will reemerge. So we know that if they stop the drug, the type 2 diabetes will settle out. But they're going to, obviously, depending on their weight gain, it's going to be a big issue as to how long it's going to take. So if we go, this drives me crazy. Okay, the dyslipidemia increases in serum lipids, mostly triglyceride elevation. Triglyceride elevation. The greatest risk is clozapine with olanzapine, and the moderate risk of risperidone, ziprasidone, and aripiprazole. The less risk factor is quetiapine for the dyslipidemia. So what are we recommending? Here's what you're supposed to do. Kill me here with this. Okay. Screen prior to initiating the antipsychotic medication. So this is the recommendation. So you look for personal or family history of obesity, diabetes, high cholesterol levels, hypertension, or heart disease. You take their weight and height, get their BMI, and if it's over 25. You look at the waist circumference of 40 inches in males and 35 inches in females. Blood pressure, 130 over 85. Fasting blood glucose greater than 110. Fasting cholesterol levels, HDL less than 40. Total cholesterol greater than 100. And fasting triglyceride levels less than 175. So we're trying to find out where they are in the prior to initiating treatment and how many of these levels are already in trouble. Once you've set them up, so here's your baseline, okay, and then you want to take the weight, the BMI. Now that's a sensitive issue, okay, taking weight with people. They're not real happy about doing that a lot of the times, especially if they're significantly overweight. But you want to do it every 4 weeks, 8 weeks, up to 12 weeks, and then thereafter, if they're stable, you can continue quarterly. Okay. Waist circumference is a good measure in terms of defining how bad the situation is, and you want to take that annually. The blood pressure you want to take initially at the time, and then you want to repeat it again in 12 weeks, and then do it annually thereafter. Your fasting plasma glucose baseline, 12 weeks, and then annually. And then fasting lipid is baseline, and then 12 weeks, and then every 5 years if you need to. So the biggest monitoring is in the BMI. And if you have an EMR, you probably have the capacity to record it every time you see the patient. So depending on how often you're seeing them, it may be as often as once every week for a while. You're collecting enough data that's going to help you. What are the practical considerations when you think about this metabolic syndrome? Practical, a scale and a blood pressure cuff may be the most useful pieces of monitoring equipment to keep in your office. Patients most likely to run into problems with metabolic syndrome or diabetes are those with the greatest risk factors for these conditions before pharmacotherapy. So if they were large, if they were overweight, their BMI was up, those are the ones that are at greater risk. Pay close attention to those with baseline obesity, dyslipidemias, and personal and family history of diabetes. If the patient has gained more than 5% of the body weight, or has a BMI greater than 30, check glucose and lipid levels as frequently as every month until you are convinced the patient is medically stable. A fasting glucose or a finger stick is probably more useful than a hemoglobin A1C unless the patient is already diabetic. The A1C is probably too global and blunt an assessment to tell you what is happening on a day-to-day basis. This is a 90, the A1C is a 90-day statement. It's like telling you what they have been doing in the past 3 months and whether they've been deviating a lot with regard to their sugar level. So it doesn't tell you day to day. It just tells you what's been happening over the last 3 months. So here are the practical things we want to do. Screening and monitoring, screen glucose and lipid levels. Repeat labs at 3 months, fasting glucose and lipid levels after initiation of therapy, and repeat once a year as indicated. Screen and monitor weight and BP and elicit symptoms of diabetes like polydipsia, polyuria, hyperphagia at every visit. So you might want to ask them about that. You're urinating a lot, you're thirsty all the time, you're hungry all the time, that type of thing. So when we look at specific drugs, here's what we should do, okay? So clozaril has some hematological effects. In addition to monitoring the metabolic effects, you got to keep alert to the decreases in the leukocyte count. Agranulocytosis is defined as a drop in absolute neutrophil count, ANC, the absolute neutrophil count, to less than 500 per millimeter cubed. Potentially lethal side effects can occur in less than 1% of the patients treated. Okay. This clozaril National Registry, if you have a patient who develops agranulocytosis or any serious side effect associated with clozaril, you have to register it. In the U.S., all patients who are taking clozaril are entered into a national registry. So you have to, even before you prescribe it, you have to basically seek registration with the clozaril National Registry. 5-year data revealed that 99,502 patients were treated with this drug. 2.95% developed leukopenia, so the white blood cell was dropping down to 3.5. Then you had a 0.38% of patients who developed agranulocytosis, so their level was less than 500. And then you see how many patients actually were fatal out of these almost 100,000 people. There was only 12 patients that died. So we spend a lot of time on rare occurrences. Uh-oh. There we go. So a fair number of patients will worry. We call those worrying patients. Some may occasionally run WBCs between 3,000 and 4,000, 200, sometimes for several weeks. So they'll have a low level, but they're not at the point where we're going to panic yet. Some may show dramatic decreases as much as 5,000 and 8,000 cells from 1 week to the next. In patients who have been benefiting from treatment or who have not been taking clozapine long enough for outcome to be clear, just take the CBCs twice weekly until the count seems to have risen again. So you just follow up with some more monitoring there, twice a week if you have to get yourself out of the worry court, so to speak. Getting several weekly CBCs before starting a clonazepam treatment helps identify patients who are likely to run low leukocyte counts. You will worry less about such a patient if the low count is known to be characteristic of them. Should the agranulocytosis clearly occur, or should the count drop below 3,000 cells, clozapine treatment should be stopped. Follow the guidelines as recommended by APA. So here we are. We're looking at a situation where the WBC count is 3,000 to 3,500, are dropped significantly, or immature cell forms are present. So what do? You repeat the WBC count and differential count. Advise the patient to immediately report appearance of fever, sore throat, or other signs of infection, because they don't have the defenses. That's what that issue's about. If repeat WBC count is 3,000 to 3,500, and the absolute neutrophil count is greater than 1,500, and no immature cells are found, continue clozapine therapy. Further, twice weekly WBC count and differential until WBC count is greater than 3,500 and cell differential is normal. Now, if it drops to 2,000 to 3,000, or the absolute neutrophil count is 1,000 to 1,500, interrupt clozapine therapy and notify the registry. WBC counts with differential daily until the WBC count goes back to 3,000 and above, or the ANC is greater than 1,500. So then what you expect to see is the WBC count greater than 30,000 and the ANC greater than 1,500, and no symptoms of infection are present. That's what you're going for when you do this action over here. You're doing this to get this. Further action down the road here, maybe restart clonazepam with twice weekly WBC count until WBC count is greater than 3,500, then WBC count weekly for 6 months. You keep drawing it weekly for 6 months. That's after you re-challenge them. The WBC count, when it's less than 2,000, or the absolute neutrophil count is under 1,000, and ANC is less than 500. That's agranulocytosis with signs of infection, fever, malaise, weakness, lethargy, constitutes a medical emergency. Immediately and permanently discontinue clozapine. Monitor the patient closely for fever and other signs of infection. Order daily tests until the WBC count return to normal, and the WBC count will be greater than 3,500 and the ANC will be greater than 1,500. So the results, WBC and WBC count is greater than, if the WBC count is greater than 3,500, repeat the post-treatment WBC count and differential weekly for 4 weeks. Consult a hematologist for treatment options. Pharmacist notifies the registry for the discontinuation and provides several WBC count results. They have to be reported. So that's what you have to do if you give Clozaril. What's the likelihood you're going to give Clozaril? No, I have not. Very low. Unless you're working in a very severe population of schizophrenics. And even then, you'd have to pretty much fail everything else. Because as a rule, if you're treating chronic schizophrenic, the likelihood is they are non-employable. They have money restrictions, and they're probably under some form of public assistance for their health care. So as a rule, it's going to be low, because this is an expensive process, not just because of the drug, but also because of the monitoring process that you have to go through. Has Craig Wagner used it in a mental health center? It's a great question. Haven't asked him, but now that you bring it to my attention, I will definitely ask him. I know that Glenn is working in a mental health center over in Lafayette, so I'll have to ask him too. Those are the two that I would probably ask at this point. I think Craig is more full-time doing it, and I think Glenn is only part-time, so I'll try to find out. It's a good question. So for most of us, we'll read about it, we'll have a little understanding of it, you'll know how to answer the questions, but overall, you ain't going to do it. Okay? Now, that's just agranulocytosis. So they expect you to know that. They expect you to know the cardiac effects. Okay, well, what can happen with the cardiac effects? You get a tachycardia caused by alpha-adrenergic blockade that the drug does. I work for a state agency, and the requirements to use clozapine are very strict, as they should be, because it's an expensive proposition. Orthostatic hypotension, anticholinergic activity, and then you have this myocarditis and cardiomyopathy that's associated with Clozaril. So from 5.5 100 cases out of 1,000 patients years develop myocarditis with ST and T wave abnormalities or arrhythmias. Etiology is unknown. 85% of the myocarditis cases occurred during the first 2 months of therapy, so it comes on early. 80% of the cardiomyopathy involves patients younger than 50 years of age. 30% of the incidences resulted in death. 20% of the incidences resulted in death. This might be more of a killer than the agranulocytosis. Practical recommendation, get a baseline EKG, particularly if there is a personal or family history of any heart disease. Consider cardiologist consultation if you detect development of respiratory or cardiovascular symptoms. We also have to deal with the seizure effects. The risk is 5 to 10%. Etiology is unclear. Rapid escalation in dosage or high plasma levels may account for the development of the seizures. That's what's thought, not necessarily true. Occurs most often in dosages of greater than 600 milligrams per day. The relationship between plasma levels and seizures is inconsistent. Practical consideration, here's what you want to do. Obtain a baseline EEG in patients with an increased risk of seizures, such as previous head injury or loss of consciousness. We've got a little hepatic toxicity as well. So the adverse effects, monitoring, no, missed one more. Missed a lot. Here we go. Hepatic toxicity. Asymptomatic elevation of transaminases, that's the ALT, AST levels, is observed most commonly affecting between commonly affecting between 20 to 50% of the patients. Hepatitis actually arises in 0.6% of the patients. Fatal acute fulminant hepatitis has been known to arise in about 0.001% of the patients. What are the practical considerations? Just get baseline transaminase levels, and particularly for patients with high risk. Repeat transaminase levels as clinically indicated. Yeah, that's it. Okay, so what do you do pre-treatment? AIMS, which is really nothing unless they're actively showing signs. Weight, fasting, blood glucose and lipids, liver function tests, CBC with differential SMA7 and magnesium, blood pressure and pulse, and then baseline EKG and EEG. So that's what you get on the front end. Adverse effects monitoring, AIMS every 6 months, blood pressure, pulse, BMI with each visit, fasting blood glucose and lipids within 3 months, and then finally during treatment. More frequently for patients with diabetes who have gained greater than 5% of their initial weight. Monitor for signs of ketoacidosis that include rapid onset of polyuria, polydipsia, weight loss, nausea, vomiting, dehydration, rapid respiration, weakness, and clouding of sensorium. CBC with differential, looking at the WBC and the ANC, weekly for 6 months, every 2 weeks for the next 6 months, and then once a month thereafter. EKGs for selected patients, those with a personal history or family history of OTC prolongation, cardiac arrhythmia, recent MI, uncompensated heart failure, or those taking agents that prolong QT intervals. Electrolytes, those at risk for electrolyte disturbances, such as those on diuretics, should have periodic serum, potassium, and magnesium requirements, or measurements rather. So that's how you monitor them. It's a lot of work. You'll see it's even more problematic given the fact that these other ones are so easy to monitor. Okay, so we have Risperdal. Has a class warning effect, which other atypicals are associated with increased mortality in elderly patients with dementia-related psychosis. Okay, the risk is calculated to be 1.6-fold higher risk of mortality for an atypical compared to a placebo. The atypical rate is 4.5% compared to 2.3% with placebo. Class is ending in 2 minutes. It is. I kind of like to finish this if you guys are up for it. Can we finish it? I am. Okay. If those of you that are and those of you not, that's okay. I'd like to get through this because I think this is going to be helpful for you when you start thinking about monitoring.
Professor, the class ends in another hour at 4 p.m. Pacific Standard Time.
That's right. Okay. Yeah, we're okay. Okay. So we have Risperdal. Class warning, like I said, the risk for all atypicals is this: atypical rate of 4.5% compared to placebo at 2.3%. Okay, so most of these deaths were cardiovascular or infectious causes. Infectious cases appear to be related to esophageal dysmotility and aspiration. That's what they think is causing it. But there is a risk of stroke-related mortality associated with Risperdal use in demented elderly. The current data indicates an increase of about 1 per 1,000 patient years with Risperdal. The practical considerations: warn the family and get informed consent. Keep the dose low in elderly patients and avoid pronounced alpha-1 receptor blockade and resultant hypotension, which may increase the risk of stroke. So, big looming question, and I don't have an answer. I wish I did. The question is this: the rates, these increased rates, the cardiovascular and infectious causes, do you have some protection if you're using small amounts? What would you say? One, it seems rational that it would, okay? And certainly I could make the case that, you know, if I gave somebody 25 milligrams of quetiapine, an elderly person who was having some trouble with sleep and was anxious, and there was no increased weight or anything that I could observe, there's no changes in any of the parameters of their, like the glucose and blood pressure, all of that, then I could argue, well, sure, it seems like we are reasonably safe, okay? But the other issue is, we don't really know that. It's kind of a guess. So what would you compare the dose if you were using? Well, that's just it. When you're actually using it to treat something like schizophrenia, you know you're going to be on, like with, when you think of Risperdal, what's the typical dose for a schizophrenic? It's got to be 3 milligrams, somewhere around there. Maybe 2 to 3 milligrams. It used to be considered higher, but it was not necessary to get the relief that you're after. So we have this idea, well, maybe I can give a half a milligram and it'll be okay. We don't know that. You know, we honestly don't know it. So a lot of people are arguing, if you're going to do it with an elderly person, maybe you should just do it for a period of 3 months and then try to get them off of it if you can. Yes, they do respond at lower doses. That's true. That's absolutely true. So, but as best I can tell, nobody can really pinpoint that this is a dose-response issue. It's a class issue right now. So you take a little bit of a risk when you step out on that limb. Strongly because they get put on it and they don't know who takes the time to reevaluate it to take it off, okay? So you really do want to go low and you want to go slow, but you don't want to, you know, one of the things is this, it depends on what you're trying to control. There's not a lot of good data that says these drugs control agitation, except through sedation. So when you sedate them, you know, you're going to have to give enough to sedate them, and then what you're going to probably have to do is try to kind of taper off, because you don't want to keep giving them high doses, because you know you're putting yourself at increasing risk. So it's a little bit of a guessing game on how to handle it. And everybody has their own opinion, and that's what this is based on more than anything. So it's where you're working, and how much you're comfortable with risk, and what you're prepared to live with, and hopefully you don't kill anybody in the process. So we use these all the time, and I do worry about it, but I see that a lot of people benefit by it, because if you're on a relatively low dose of something like Risperdal, maybe it's a 0.5, you know, and that might be something I'm putting somebody who's really agitated, hallucinating. I feel better giving the drug when I can point to some psychosis and not just somebody being irritated or not sleeping. It's much, you know, you're not going to get any trouble if you're treating a psychosis, because everybody knows that's what you got to do. You just tell the family there's a risk, okay? But the risk is relatively small when you really think about it, but it does double the risk. And then the question becomes, were these people somewhat sicker, obviously, than the people that were getting, you know, if they had a real bad condition, what was the comparison group? And how healthy were they in the first place? So that's another thing. And I don't think we have all that data. At least I don't. I'd like to know. What is CMS's perspective in response to the PEP6's why are they pushing the to get them off the antipsychotics? Because there's been a feeling that they were overutilized for a long period of time, and that there were problems arising from it. Not just the risk of the diabetes, the stroke. They want them off if they can. And some of these are also expensive, but the older ones are not so bad, like Risperdal. But I think there's this general feeling, because the data hasn't been convincing, that this controls agitation very well. Yeah. We use very low doses for irritability, violent acting out. Yep, everybody's doing it, but they are in the hospital setting where they can be closely monitored. That won't necessarily stop the stroke or heart failure. It makes you feel a little bit more comfortable. But once a stroke, I mean, it's not like you know that this person's going to have a stroke unless he starts having TIAs. Okay, it's a risk, but we do it. We got to do it. Sopranolol, Judon. So cardiac problems, you get this QT prolongation. It represents the period of cardiac repolarization of the ventricular action potential. So the mean is roughly about 400 milliseconds with a standard deviation of 25 to 30 milliseconds. When it increases beyond 450 to 475 milliseconds, the risk of cardiac arrhythmia increases significantly, such as in what will happen, you'll see torsades de pointes and ventricular fibrillation. Among the second, what do we got? I've seen Risperdal used with very aggressive and moody children in autism spectrum. Mm-hmm. What is it? Yeah, I understand. I know why they do it, but there's not a lot of good literature to support it, I can tell you that. But at least you're probably not going to get heart failure. because these are old people we're talking about. Young people can tolerate these things better. So I don't treat kids, thank God. That's another mess. Okay, so where did I leave off? Okay, among the second generation antipsychotics, suprazodone is associated with, that's a crazy sentence, suprazodone is associated with the greatest QT prolongation. So in other words, this is the worst for the, Geodon is the worst for cardiac prolongation. You should know that. You definitely should know that. And these are the prolonged periods here. 15.9 milliseconds, 5.7 milliseconds for quetiapine. Risperidone is 3.8, so it's a little safer. And olanzapine is 1.7, it's a little safer there. Risk appears to be close dose-related effect. Now we know this is a dose-related effect. We don't know that about the other stuff. Okay. The practical consideration, EKGs may be useful for select patients. So you can lower the dose as a way of compensating for that problem. You can, quetiapine has this lenticular opacities. Its concerns for his cataracts in patients treated with quetiapine is probably overstated. Initial studies supporting the risk were done with dogs receiving 4 times the maximum recommended human dose. The dogs developed cataracts following 6 to 12 months of exposure. So post-marketing surveillance since 1998 have revealed an increased rate of cardiac formation in human patients. The practical consideration, the manufacturer recommends ocular examinations every 6 months, but few practitioners follow that recommendation because they don't see it as a major issue. But it can do that. It has some hepatic issues as well as thyroid issues. During clinical trials, asymptomatic transient and reversible elevations in certain transaminases, the ALT being higher than the AST, were observed at a rate of about 6% compared to the placebo rate at about 1%. So it's a relatively small percentage, but it's there. Elevations typically arose during the first 3 weeks, so it happens early in therapy, and prominently returned to baseline levels when it was discontinued. Practical considerations, none, really. Just stop using it. Thyroid effects during clinical trials, a dose-related decrease of approximately 20% in total and free thyroid was observed at higher end doses. So that would be fairly large doses. Typically arose in the first 2 to 4 weeks of therapy with no further changes with chronic therapy. T4 levels were of no clinical significance and TSH was unchanged. An increase in TSH occurred in about 0.4% of the patients. Practical consideration. In patients with bipolar disorder, depression, relative hypothyroidism can be associated with a reduced response rate to an antidepressant treatment. With this population, monitoring and the correction of relatively hypothyroidism may be indicated. So you have to watch for that population. Those are high doses. Whoa. Sorry. So olanzapine. Oh gosh, I hate it when it does that to me. I think that's it. Yeah. That's good time. Okay, great. Why does it do that? So olanzapine, Zyprexa. Mild elevations of liver transaminases may be seen. These are stable or decline over time without progression to hepatic dysfunction. Practical consideration, absolutely none. Prolactin elevation occurs early in treatment, but levels are much lower than seen with the risperidone. May exceed normal levels in patients taking 30 milligrams or more per day. Practical consideration, monitor for clinical signs of hypoprolactemia. So that's what you'll do with that. Always jumps one forward. I don't get that. Iloperidone, most common side effects: hypotension, dizziness, somnolence, tachycardia, nausea, xerostoma, that's dry mouth, weight gain, diarrhea. You can get orthostatic hypotension. 5% of the patients given 20 to 24 milligrams a day, 3% of the patients given 10. So it's a dose response, and then 1% per patient given placebo. Requires slow titrations, so you're less likely to get the orthostatic hypotension if you go up slowly. The weight gain, greater than 7%. Body weight was 13% for FANAP combined doses versus 4% for placebo. QT prolongation, 9 milliseconds. It's not all that big of an issue. Acenapine, common side effects: akathisia, oral hypoesthesia, somnolence, dizziness, extrapyramidal side effects other than akathisia, and weight gain, insomnia, headache. Weight gain, moderate. In a 52-week study, the proportion of patients with a greater than 7% increase in body weight was 14.7%. EPS and akathisia, moderate EPS related to events, excluding those related to akathisia, is 7% for Saffris versus 2% for placebo. The incidence of akathisia-related events is 4% for Saffris and 2% for placebo. QT prolongation is a low risk interval ranging from 2 to 5 milliseconds compared to placebo. Lorazepam, common side effects: nausea, somnolence, EPS, akathisia, Parkinsonism, dystonia, anxiety, agitation. Weight gain, moderate, low. Proportion of patients with clinically significant weight gain is greater than 7%, 4% placebo, 5.6% with lorazepam. QT prolongation is low risk, interval ranging from 2 to 5 milliseconds. EPS, moderate risk. Incidence of akathisia is 12%, so that's fairly high. Everybody knows what that feels like, right? Got to move. You got to move. Incidence of EPS related to events. Yeah, it's an internally driven restlessness. EPS-related events, excluding akathisia and restlessness, 14.7% versus 5.1% for placebo-treated patients. Those placebos are awful powerful, aren't they now? So, pre-treatment. So we do an Ames, we get blood pressure, BMI, weight, fasting blood glucose, and lipids, CBC, differential platelets, SMA, that's serum multi-assay 7, TSH, T4, and LFTs, urine pregnancy tests as clinically indicated.